Welcome, everyone. I'm Sharon Terry. I'm the president and CEO of Genetic Alliance and want to welcome you to this webinar today. This is the second of a series of three. These are focused on the National Academy's report, Newborn Screening in the United States, a vision for sustaining and advancing excellence. And as we all know, this is a really highly critical report, a critical time, and a report that's important to this critical time. This particular webinar is Newborn Screening as a High Quality Public Service for All. And we'll have several speakers with us today and then plenty of time for Q&A. We welcome questions. You can put those throughout this time in the chat if you wish, or you can wait and you can ask those verbally as we conclude the formal piece of the webinar. So without further ado, I'm going to turn this over to Jewel Mullen, who's at the University of Texas at Austin Dell Medical School, who was the committee chair. So Jewel.
Thank you, Sharon. Good afternoon, everyone. Good morning if you're not on Eastern time. If I've been sitting here smiling as we've been waiting to begin, it's because there are a number of committee members who have joined into this call. As the chair, I am not one of the experts in newborn screening. I'm newborn screening adjacent, but the smile is my recognition of the fantastic committee members that helped produce this report, their dedication, their expertise, their commitment, and the fact that we're having this opportunity to do webinar number 2 with you is just something that makes me happy as we look to the future. So, as we move forward in thanking the Genetic Alliance, we're going to discuss the report's vision for public health newborn screening as a high-quality service for all infants born in the U.S. And Emily Packard-Dawson, thank you for advancing to the next slide for me. Newborn screening is a public health service for all infants. It's one of the most far-reaching public health programs in the United States. It reaches over 98% of the 3.6 million babies that are born each year. It's designed to identify infants who are at risk for serious, treatable conditions with the goal that they be connected to care early before symptoms appear. While there are different forms of newborn screening, our focus today and the focus of our committee was on the dry blood spot screening, which identifies more than 7,000 infants every year who may benefit from timely intervention. Screenings delivered through state and territorial programs supported by a broad network of federal clinical and advocacy partners. And together, this system is critical in improving outcomes for babies across the country. And in the next slide. The task of our committee was to examine the current landscape of newborn screening in the U.S., recommend options to strengthen screening, and to establish a vision for the future of newborn screening. I already talked about the fantastic committee that we had. There were 14 members who span multiple domains: state and federal public health, lived experience, bioethics, law, emerging technologies, etc. We reviewed literature, held public workshops, and received input from over 600 people across newborn screening through a public engagement activity. You can go on to the next slide. Our report offers 9 recommendations to guide action across newborn screening and sustain excellence into the future. Every recommendation reflects an essential function for public health newborn screening, identified here in the blood spots. While the written report was released prior to changes at HHS and the disbanding of the Advisory Committee on Heritable Disorders of Newborn Children, we are clear that this report can serve as a roadmap for the functions that are needed to sustain and advance this valuable public health service. I will say more than once that there are roles for everyone across the newborn screening ecosystem to take this work forward. Today, we're going to focus on the vision underpinning the recommendations, a vision for excellent public health service for all infants born in the US. We can move on. We were fortunate to spend a lot of time in what felt like a very accelerated time frame, really deep diving on our committee's vision of what contributes to excellence in newborn screening. We identified effectiveness, trustworthiness, and equity as foundational to the excellence in newborn screening. Our definitions for those three are on the slide. And they're not standalone concepts. They overlap and reinforce one another. For example, a program can only be effective if it earns the trust of families it's meant to serve, and if all babies can benefit from it. Given the time constraints that we have today, we're going to focus on trustworthiness and equity. So let's start with trustworthiness and what it means in the context of public health newborn screening and why it may matter now more than ever. We can go on to the next slide. Trustworthiness is central to a public health newborn screening system that people can rely on. Trust isn't automatic. It has to be built and maintained over time. Public health newborn screening programs must deserve the trust of those who participate in it and rely on them. But public trust in newborn screening faces a number of challenges. Many families report that they don't feel informed about newborn screening. Concerns have also grown about how residual dried blood spots are handled, particularly in the absence of clear and consistent policies. And these concerns occur within a broader context of declining trust in institutions, including science, medicine, and government, and growing unease around privacy and data use. All of those can shape how families view newborn screening and whether they feel comfortable participating in it. Our report makes it clear that trust must be intentionally and consistently built. That requires transparent governance, clear communication and engagement, and decision-making that's grounded in ethical, scientific, and professional standards. Moving on. Here and throughout, we highlight the voices of those who participated in public engagement sessions and in some of our public meetings, starting with this quote that captures a family's desire to be informed and included. Clear communication, openness, and transparency would help build trust. People want to understand what's happening and why, what's being screened for, how results are used, and what options exist for them. This isn't just a communication challenge, it's an opportunity to build trust through engagement and transparency. Moving on. To expand public and professional, to earn trust, we call for expanding public and professional newborn screening education and awareness, assuring that professional associations involved in perinatal and infant care should issue recommendations for communication about newborn screening. So once again, one of the clearest opportunities here is for communication. Since families often report that they don't feel fully informed about newborn screening, what it is, why it matters, or what to expect. But it's not just families, because sometimes healthcare providers also express uncertainty about when to introduce the topic, what to say, and how to explain options. That creates more communication gaps that can affect how confident families feel engaging with the screening process and any follow-up. Our committee recognizes this as an important opportunity, and our report calls for expanded education and awareness efforts aimed at both families and the professionals who support them. efforts that should begin during pregnancy and continue through the postpartum period. We discussed in detail that healthcare providers need tools and training to talk about what newborn screening is, how it happens, what the results mean, and what options parents have. We acknowledge that there are many high-quality materials available. So this recommendation isn't just about creating materials, but really assuring that they are used consistently by providers who understand them and that they are tailored to local needs. Moving on. Another key issue that emerged is how residual dried blood spots and any derived data are stored, shared, and used. We acknowledge that the samples are essential to the integrity of newborn screening, but residual dried blood spot practices and data differ across states and territories. In some cases, samples have been accessed by law enforcement, raising privacy concerns and legal challenges. That contributes to public skepticism. And as one newborn screening public health professional put it, although these blood spots have amazing potential for equitable public health research, the failure to protect blood spots from misuse is in criminal investigations, and a lack of transparency in storing these severely damages public trust. So we need a balance between ensuring dried blood spots can support essential services
for a longer period of time. I think I can.
And I'm not sure whether I'm the only person who can hear someone who needs to go on mute, but I wanted to let you know I can hear your conversation.
Yeah, I can hear him too, and I'm trying to mute him. Sorry.
Okay, that's fine. While also respecting family expectations. Also, for earning trust, we saw an important opportunity to strengthen it by having state legislatures specify standards for retention, sharing, and use of newborn dried blood spots and derived data. Our report calls for protecting sample retention for core public health uses, something that state legislatures can act on, making other uses such as research transparent and explainable to families, another policy that can be advanced at the state level, allowing parents to request destruction after a minimum retention period, allowing individuals to request destruction of their own sample when they reach adulthood, and again, prohibiting the use of dried blood spots in criminal, civil, or administrative investigations. We can move on. Voice of Another Parent addresses the lack of uniformity from state to state in the newborn screening program processes. This is evident as we highlight that one of the most visible and frequently discussed equity issues in newborn screening is variation in conditions screened across states and territories. As the parent stated, luck or happenstance shouldn't be a factor in determining if a child has a rare disease not immediately apparent at birth. The quote reflects what variability can feel like to families. Even conditions that are federally recommended through the RUSP, the Recommended Newborn Screening Panel, are not required to be adopted in every state, meaning that screening for a particular condition may differ depending on where a baby is born. The committee recognized this is a meaningful equity concern. Differences in access to screening can have real implications for patients and families and their outcomes. But geographic equity is only one piece of this. There are a number of dimensions of equity that we identified, and you see them listed here. They involve how decisions are made, to whether or not babies receive follow-up testing, treatment, and ongoing care. Although screening reaches nearly all babies, it doesn't ensure that every infant benefits equally. Differences in access, timeliness, and quality affect how well newborn screening serves its purpose. And so we discuss these various equity dimensions related to policy, geography, assay performance, diagnosis, care and treatment, and research and attention. National advisory bodies don't always reflect the full range of committees and communities affected by newborn screening. Availability of follow-up services such as the genetic counseling or specialty care also varies widely across states and territories. Infants of non-European descent are at higher risk of receiving false positives and false negatives. And fewer Medicaid-enrolled children receive evidence-based care than their privately insured peers for certain conditions. Equity is a cornerstone of excellence in public health newborn screening. So expanding screening without addressing existing gaps in care, diagnosis, and access falls short of its potential. On the next slide, we list and identify some selected actions to address inequities that we know need to be mitigated. The committee identified specific areas where targeted action within the scope of newborn screening could address different equity dimensions. From the perspective of policy and input, national advisory bodies like the Advisory Committee on Heritable Diseases of Newborns and Children have helped shape priorities and implementation decisions, but they haven't always reflected the full diversity of affected communities. That's the reason that our committee calls for convening a multi-interest holder advisory body and expanding research into public perspectives as part of informing ethical decisions. Addressing geographic variation, we acknowledge that where a baby is born can influence whether they're screened for certain conditions. To address this, we call for establishing a national performance system to assess and improve quality. Federal support for programs through targeted funding and technical assistance that's responsive to measured performance, and building infrastructure for resource sharing among newborn screening programs. We don't say that this has to happen in every program or state, but that every program needs to be able to access resources when needed. Our report also calls for accessing and data collection to assess and improve assay performance, and emphasizing the need for newborn screening programs to document diagnoses to make sure babies are connected to care and to prove handoff from newborn screenings to programs to clinical care. As we know that diagnosis is a critical step following a positive screen. This next quote from a researcher reminds us that there's a growing interest in expanding newborn screening, and it's just as important to consider how well the current system is serving all families. Through its information gathering and public engagement, the committee heard that people want a system that's clear, consistent, and supportive, not just at the point of screening, but from prenatal communication through to follow-up. The recommendations and actions discussed today aim to support a system that's effective, trustworthy, and better able to serve all infants and families now into the future. And as I stated at the beginning, I want to reinforce one of the clearest messages from the report, that there's a role for everyone in shaping the future of newborn screening. Whether you're a public health professional, provider, policymaker, parent, or advocate, you can help move these recommendations forward. And these recommendations, materials here, were developed to support that. Everyone's tailored to a different part of the system: newborn screening programs, researchers, providers, and professional societies, families, and the rare disease community, so that everyone has a starting point for action. And once again, thank you to my fellow committee members.
Wonderful. Thank you so much, Jewel. I want to thank you for chairing the committee. Just on a high level, I'd say having chaired several of these committees, I know it's a lot of work, and as a volunteer, that's really phenomenal. I'm the chair of the Health Science Policy Board, and we're also very excited to have this report out and to have had this very timely committee work and your work. So thank you so much.
Thank you. Thank you.
Okay, we're going to have 3 respondents give us some of their reflections, and I'll name them and then introduce them each as they're coming up. So first, Beth Torini, Children's National Hospital. Beth was a committee member, and then after her, Sabra Ankner from Green Blanket Consulting, and after her, Jennifer Waldrop, who's the executive director of the Rare Disease Diversity Coalition. So Beth, you're up.
Sure, thank you. Thank you, Sharon, for inviting me. Thank you, Jewel, for leading the committee, and the National Academy for making the report possible. It was a privilege to serve, and I think it was eye-opening and learning for me as well. So a few reflections on what Jewel has gone through. I think the key point is that there is a place for everyone, which signals what I think many of us here understand, and that is that that newborn screening is a system that involves a lot of moving parts, and it is, as many of us know, quite remarkable that it has been so successful in doing what it has done and saving children's lives in the last 60 plus years. And as we talk about issues related to equity, and families and delivery, I think the one important part and reflection I've had is the system and ensuring that our system is solid and works, and we have robust and supported processes across the many aspects of the system, across the many key partners we have, from the hospitals to the states, to the providers, and the families. And of course, all of that is easier said than done, but we've been able to do what I would say is an excellent job so far. I think there are places where we can improve in that system, and I think as we improve a system, we will also address issues of equity. Just as a natural corollary, there was a comment in the chat about the committee focusing on existing disorders. And some of that, I think, in that conversation I was involved in, gets to the idea of we need to make sure we're doing meeting the moment on the disorders we already have in terms of our delivery, in terms of what we're delivering to parents and their families, before we can really strongly embrace additional technologies and disorders. I'm not saying that we have to stop, but I'm saying that we have to attend to our house and its strength as we also look to the future to embrace new technologies and new disorders and new treatments. And to that end, I think an area also that has resonated with me in my career and in the report is the role of families. And we, as a provider, as a general pediatrician, as Sharon pointed out, my people, if you will, serve as a nexus between the program and the families. And we are often the first point of contact, which in what is not a common, if you will, everyday occurrence for us in our practices. And so how the first point of contact often to the parents feels in terms of their ability, their efficacy to provide the guidance, provide the news to the family of an out-of-range newborn screen, and guide the family through the process, is, I think, an area in which we can do a lot more. Again, especially as we get more complex disorders with more complex evaluations as part of them. So I'll stop there. Oh, I think you're on mute, Sharon.
Thank you. Thanks very much for your service too, Beth, and thanks for your comments. And Sabra, you are up next.
Thank you so much, and thank you for including me. I was not part of the committee, so my perspective is perhaps a little bit different in that I come to it as like many of you, as having read it and had an opportunity to reflect on it. to be clear, I'm speaking on behalf of myself, and that even barely. I am not speaking on behalf of any programs of which I previously worked or might currently be working with. So this is just my own thoughts. I do think that high quality service for all is a goal, but it is not where we are, and that we need to really recognize that we are racing forward towards things. And as Beth was just saying, without actually understanding if what we are currently doing is working, and who it is that we are providing service for. There are not 56 blood spot screening programs in the United States. There are 56 jurisdictions, 50 states, the District of Columbia, and 5 territories, but there's not 56 programs, because the territory of American Samoa has 40,000 people, its population, and 800 babies born every year, and not one of them has ever had newborn blood spot screening. So we have this belief of who we are and what we do that is not reflective of what we actually are and what we actually do. Now, fortunately, as mentioned, that we need investments in this. American Samoa did get some of the Propel funding, and we are working towards initiating a very specific, to them and their specific context, screening program that will launch by the end of this calendar year for one condition. We're starting with congenital hypothyroid, and we'll move from there in collaboration with the folks in New Zealand, who are geographically much closer to American Samoa than any of the rest of us. And I'm thankful for that funding. Additionally, I think Lori is here from who's working with the Republic of the Marshall Islands, which is one of 3 Pacific island nations that the United States has compacts with, treaties where we provide them with health services. But again, we have never supported them in developing any newborn screening programs. So the Republic of the Marshall Islands is working to launch their own newborn screening program. Palau and the Federated States of Micronesia still remain not having any screening programs. I want to also just talk about the concept of good genes and bad genes. This is in the news right now. We're having a lot of conversation about what good genes and bad genes are, and an ad campaign or comments by our government officials, and how this conversation and also newborn screening and how we discuss it and what we screen for can stigmatize not just individuals, but entire communities and populations. And that is really crucial to acknowledge and be aware of, and to say that there is no such thing as genetic privacy, right? It's not a thing. As soon as you start sequencing somebody's genome, you can identify who they are and also often what community they come from. And this is really, really important when we are literally having conversations about whether eugenics is a good thing or not, is a conversation in our country right now, that we be hyper aware of what our role is in that discussion, and how we are discussing the testing that we're doing, what we're screening for, how we're communicating it, and what it means. Genetically isolated populations truly they stand to benefit the most in a lot of ways from universal screening programs. But they also stand to be the most harmed from those programs. Many of you know that I used to manage the program in Alaska, and there we have a condition that is specific to coastal populations of indigenous people in the Arctic. And there sure was a lot of interest in that information and that data from researchers all over the world. But they weren't interested in working with the communities, right? They weren't necessarily interested in having conversations about the origins of the CPT1A Arctic variant and the positive adaptations that was indicative of. And, it was a challenging thing to address and to figure out how to discuss. And, and it goes to that these populations have been underrepresented, not just in research, but in the precursors to research, to the conversations that we have and what we're interested in and who may benefit from understanding these things. So which I just say that trust must be worked towards and earned. And it can only be accomplished through having conversations with communities. The reasons that families say they're not fully informed is because they're not, right? It's not a perception issue. It's because they're not fully informed. Providers are not fully informed because we don't consent most things, right? We are not asking for permission. We are doing what we think is best, and there are potentially good reasons for that. But as we expand testing, as we expand uses of blood spot, we're still not asking for permission, and we're not being transparent about what we're doing with those specimens. We, instead of doing opt-in, we go opt-out, or sometimes just silence. There are folks on this call, not to call anybody out, but just again to say literally what we're dealing with here, who, if their program was approached by law enforcement today, would release data. Who, if their program was approached today for researchers with a research goal of some sort that maybe has nothing to do with newborns to benefit that newborn, would release and or sell the residual dried blood spots. And this is not something that the vast majority of families appreciate or understand, or the providers for that matter would appreciate or understand that that could be happening. So I think, you know, the newborn screening program nationally, globally does phenomenal work. But we have a lot of work to do to ensure that every baby in the United States, no matter where they're born, no matter how far that island is from the mainland of the United States, can benefit equitably through also having access to actual high quality care, to treatment, to trusted healthcare providers who literally and figuratively understand them and understand their language, and who can meet the needs across the lifespan. So thanks.
Thank you, Sabra. Jennifer, you are up next.
Thank you. Thanks, Sabra. That was great. So I'm Jennifer Waldrop. I'm the Executive Director of the Rare Disease Diversity Coalition. And I think it's important for you to know that, because in this role that I have, I'm so honored to be a part of, it really is hyper-focused on the rare disease community and for the historically marginalized, underrepresented populations. And thinking about what Sabra just said, when you think about these populations and you're comparing the current maybe information and research we have, do we have enough data to truly think about it through the lens of those that are generally not studied? And so that's how we kind of double down on for this coalition. For us, our mission is to narrow the disparities that's happening in the rare disease community. And to do that, I think it really does start with the neonatal early stages of both being pregnant as well as the newborn screening process. So when you think about the communities that I serve, you think about probably the Black and Brown communities, for example, but you also may want to expand that thinking into the rural populations, and think about maybe the islands, as Sabra has mentioned as well. That being said, those populations are often not having the same type of healthcare, quality of care, health outcomes, as everything has been alluded to in this conversation. And those slides with the trust up there is absolutely an underscoring and under issue for these communities. That being said, when I look at this report, there's so many things in there that I'm sure my coalition members have added to the research to this and their lived experiences. And that's exactly my role, is to advocate for these folks that have are part of the rare disease, and whether they're a caregiver with a child that's living with the disease or one that has passed, I hear those stories. And when I hear these stories and I hear about the different communities in everything that has been discussed so far, I just wanted to basically give 100% to that. I think our perspective is a multi-pronged one. One is the actual screening itself has some concerns and some issues, as mentioned. It's not the same from state to state. It's not always mandated as needed. And so why not? And what's the technology there that is preventing, or what is preventing this from the technology that we have? I think that for us, as if we're trying to create an equitable with excellent outcomes for all, that is one of the areas of opportunities that we can improve our healthcare system. Secondly, when you think about the actual screening themselves, if they are so fortunate to get the screenings, what happens after that? Are they told in the hospital the results of the screenings? Is there a delay where they have to find out from their provider? The system's very different. And so without that consistent gold standard and that care that's been delivered for everybody, you're going to have different outcomes. And when it comes to rare diseases, as you know, the genetic testing, essentially, that 70% of rare diseases are coming from the family. So what can we do in that regards, and start with newborn screenings and other follow-up testings? So is there counselors that come along and help understand what happens with the newborn screening? Are there folks that are sharing the information in a way that is available and makes sense to the layperson, essentially, folks that are not in the healthcare area? And are they doing it from a culturally respective way? As you know, in this country, in the United States, at least in the mainland, of course, we have almost 20% of the population from Latin American background or Latino background, and probably a good number of them are Spanish speakers, and they prefer talking to others, especially when it comes to healthcare, in Spanish. That being said, there is information out there about how many genetic counselors there are that speak Spanish, and it's pretty low. From what I understand, it's about 3%. So when you have folks that are either providers, you have genetic counselors doing the follow-up from the testing, and they're not able to relate to the families, things get missed and slip through the cracks. So I definitely think from a workforce perspective, there's lots of opportunities there too. When we think about also, as mentioned, doctors and really understanding perhaps these rare diseases, how are they trained? How long ago were they trained? Are they staying up with the latest information? An example is sickle cell. Many providers, many doctors may think that sickle cell is really only a disease if you are part of if you're part of Africa continent, essentially. So if you in the States, if you're part of the African American population or the Black population. But guess what? Sickle cell is actually not only impacting the African Americans, but it impacts others around the world in the equator line, because it's a disease that comes out from malaria and mosquitoes, and how the human body has evolved over time. So if you live in places like India, if you live in places in East Asia, for example, there's a greater chance that you may have sickle cell disease that runs in your family, for example. But many times providers, doctors, and others may think that it's just a Black person disease. And that holds true for some other diseases as well, and also holds true for some of the research that we do. So, from our lane, from RDDC's perspective, we do think that this report was a great report. It's a great start for folks to better understand newborn screening. It also gives a chance for patients and caregivers maybe to either relate to, because rare diseases is also very isolating. Folks that are a part of this community have a very unique way of just living their experiences. As you all know, with 300 million rare diseases around the world, or patients living with rare diseases, that's not a lot compared to the billions of people on this earth. That being said, 1 in 10, according to many studies here in the United States, are living with a rare disease. So it's probably not as rare as you think. And so if we can help it from the very beginning with the newborn screening test itself, provide the gold standard for everyone, feel it within our systems, and then at the follow-up care as needed, so that folks from these historically marginalized, underserved populations that often are not getting treated the same way as the majority populations, then we can do a better job in narrowing the gap and the realities of having this newborn screening available for all. And I think I'll just leave it there. So thank you.
Great. Thank you very much, Jennifer. Okay, the floor is open for questions. You can unmute and ask them, or raise your hand, whatever works for you. And also the respondents, if you want to respond to each other given what you said, and or Jewel, of course.
So how about this? I raised this hand but didn't put up a sign. May I?
Yes, please.
Thank you to all of the respondents, including Beth, but maybe this isn't directed as much to you, but to everyone. I really I appreciate everything that you said, and it resonates with me. The chair shouldn't really speak on behalf of the whole committee, but I'm going to say I know your points resonate with the committee as well. And so here on August 7th, I asked this question for myself and the rest of us as a former federal official and state public health commissioner. We know that we offered policy approaches. We know that we offered programmatic changes. And I love working with the national academies. I feel that it's time for me to push. So what should we really do to take the words off of the page, off of the screen, to make some inroads on so many of the issues that we know are relevant here and relevant in so many other realms too, because that gets to a lot of the equity and trust issues. They cut across newborn screening and they impact populations that we're talking about in other ways as well. So, I mean, you have the ear of committee members, so we still have a little bit of a platform. Are there specific things you would want to see us do as we continue to make the report live? Like, this webinar is really important.
Yeah, great.
Jennifer,
great
you look like you
question.
want to say something.
Yeah, go ahead.
I was trying to figure out what the question is. Is it trying to take this information that we all have been now a certain knowledge about and then helping to cascade that information? I'm trying to find what you're
And
asking.
to make change and to really make something happen so that, years from now, we actually have moved the needle on the inequities that we're talking about.
So let me sit in the RDDC spot and share with you what we are doing in this space, perhaps, even before this report came out, right? So this report, kind of like some of the reports that RDDC has, just kind of validates, I think, what many of us on this call already knew about. And that's fantastic. We need that validation. We need the science behind it. Science is real, folks. So I just want to say that regardless of this report, what RDDC has done is a couple things. One is we created a toolkit called Know Your Family Health History. For those of us that have a little gray and little wrinkles around us, you may know that concept from a long time ago, but that concept actually was not resonating and speaking to the underserved populations, or I should say specifically to the Black and Brown, perhaps Spanish-speaking populations. RDDC went ahead and retooled that toolkit essentially so that it comes across as a way that folks feel a little bit more comfortable talking about your family history. So let me speak from the I perspective. As you can see, I am a woman, identify as a woman, so she, her. I am Asian as well, and I'm of the what generation am I? X, I guess, generation. So there are certain things, and my parents are immigrants. So there are certain things that I come with from a health perspective that I see and from a generalist perspective that others that look like me have these lived experiences. And when it comes to health, we don't talk about health. My aunt had breast cancer. Don't you dare ask her about her breast cancer experience, what kind of breast cancer she has, how old she was, etc., because you just don't talk about this kind of stuff. So we know that this resonates in many communities that are in the BIPOC, the Black, Indigenous, people of color perspectives. So we put together this toolkit. In that toolkit, if you know your family's health history, that's one way, an entourage way to get into the newborn screening, right? Because if rare diseases are genetic based, then at least you have some place to start with and have a conversation if you're thinking about having children or birthing child. So those are one thing that we have done. Another thing that we've done using that same concept is work with community healthcare workers. We have a whole set of trainings with for community healthcare workers, and in that training, it includes newborn screening and advocating and educating that. We also have a fellowship education program at RDDC, and in that talks about newborn screening as well. So to Jules' point, how are you embedding some of these concepts into the communities you serve, the places you volunteer, the companies that you work for, et cetera, so that it's not another thing, but it's actually enhancing what you're currently doing, perhaps. So hopefully, Jewel, that answers a little bit of how RDDC is taking this topic and trying to improve our healthcare system. I see Heidi has raised her hand.
Heidi?
Yeah, thank you. First, thank you to Dr. Tarini for attempting to address the comment that I had put in the chat earlier. And I do totally agree with you that there is a certain amount of mess that we already have on our hands that does need to be cleaned up, and that should be a priority. But I think my question was more getting at whether we are losing the concept of public health equity in our discussions. there was a then section of the report where the committee alluded to, or stated, didn't allude to, that a certain amount of variation in state panels would be okay as long as it was addressing the population needs there. But also then warned against, those differences creating disparities. And they didn't really kind of outline how you walk that line. And I guess I was hoping somebody could kind of speak to where we kind of draw that line of going way too far into medical equality and really getting away from the public health equity goal.
I can start, and then we have some committee members who might also want to weigh in. And it's a great question, because what we were suggesting might not be how other people interpret our statement as well. And so what we sometimes acknowledge is that in particular jurisdictions, there are conditions that are more of higher prevalence, just given who the populations are that live in them. And it may be that in those, there have been programs which have then decided that they want to preferentially screen. That's a quick answer. Sabra's hand went up really fast. And I don't want to call on any committee members, but I think there are folks on the call that also work in newborn screening that might talk about what that looks like. So it's a great question.
Yeah, I
So-
can respond from the perspective of launching a state-specific program for a specific condition. So, in Alaska, we decided to screen for the CPT1A Arctic variant by genetics universally. And so, the figure that's often used is that 1 in 800 kids in the US will have a true positive finding in newborn screening. In Alaska, it's 8 in 100. So it's about 8% of the total population is homozygous for that variant. It's, about 25% of Alaska Native babies in total, really from specific regions and parts of the state. But it does impact their health, especially as infants, when they don't have any fat stores or don't have much fat stores, and when they're in hypermetabolic states, things don't go well. But it is important because it's the variant isn't always present. We were only detecting a very small proportion of them on mass spec. That was pretty inconsistent, because for the most part kids are fine until they're not, and so we weren't really seeing anything that was identifiable. But it absolutely would not make sense for 4 million babies a year to be tested for that genetic variant. But it absolutely does make sense for the 10,000 babies a year in Alaska to be tested for that variant.
And I'm happy to add something as somebody who's not a millennial, but a baby boomer. And so as a physician, I also recall the era in which it was only Black children that were screened for sickle cell diseases. And then I guess sometime in the 80s, at least where I was in Virginia, that was expanded to the entire population of infants born every year, much to the relief of some and much to the concern of others, but nevertheless a really important public health change. And that gets to part of the point that Jennifer was making earlier.
Misha.
Hi. So I want to start by saying I applaud the work of the committee and the depth and meticulousness of the report. My uncomfortable question is, what happens now? SACHARP is gone. The advisory committee on infant and maternal mortality is gone. ACHDNC is gone. The current HHS has shown us again and again it has contempt for the very idea of public health if it is willing to kill or maim the USPSTF research into vaccines, vaccine hesitancy, health disparities, fluoridation of water, etc., why would we think that newborn screening would be embraced or even spared, especially given the eugenic moment that was alluded to earlier?
Great question, Misha. Thanks for naming the elephant in the room.
I don't have to be the first one to answer, but I'm happy to be one of the people to answer. But Beth, you want to go first, or you want me to do it?
Sure. I mean, every day is a new day. But I think one frame that separates this from that perhaps separates this just slightly from some of the examples would be, and people can push back that there are other examples that would contradict this, is the focus on babies and infants. Those, as I've been told since I was a young faculty member, this is an area where people really can tend to get behind because of the patient population you're working with. I think that even in the midst of the turbulence in biomedical research, I think you have seen some traction recently around rare disease, particularly within the NIH. How much traction we get, I don't know, but I think there are sort of toeholds, if you will. Now, I'm not a policy expert. I'll defer to Sharon on this, but I think there are toeholds in this area that give it a little bit more hope than in some of the others. No doubt there are steep challenges just at baseline. There have been in newborn screening and currently. So I'll pause there.
Yeah,
Sharon is,
go ahead,
okay,
Jewel.
go on.
No, I was just saying Sabra just put a comment in the chat. Sabra, I don't know if you want to say that aloud.
Oh, well, I was just shouting out ACOG, the American, what? Now my brain's, I'm hungry. But
American
no,
College
the
of
OB-GYNs,
Obstetrics
thank
and
you.
Obstetrics
Like,
and Gynecology.
All I think is OB-GYNs. I couldn't get the AC out. But anyway, they have announced that they are going to cease accepting all federal funding. And that's, I think, scary for everybody in the field. And also, I think, really impressive. And I don't, it doesn't mean that everybody should go that direction. I certainly don't think that it would benefit like the states and territories. That's not, but for organizations whose voices are being stymied or silenced, who are being asked to not talk about things like, say, whether we know that SSRIs in pregnancy are safe, because we do know that regardless of recent FDA hearings, that it's, to me, reassuring to have groups like ACOG come out and say, we are going to say what is true instead of accepting this funding. Again, it causes, like, you wonder what happens to AIM and to Women's Preventive Service Initiative, right? There's some concerns, but I think that that's they're the first organization of their type that I've seen do that, and I do want to kind of mention that as an approach.
Yeah, thanks, Sabra.
So what I was going to say, and I know Dean's hand is up at least, is it's an important question. We've been asked different variations on it in the past. So I have a few things I just want to throw out. One of which is, this is not a stay in your lane moment. And so this notion that there's a role for everyone reinforces that everybody, has some expertise around sustaining a program. So that's number one. Also, not a stay in your lane program. Public health newborn screening is essentially a state-run program, not just a federal program. And I understand the connection there, but we've talked about the different policy and programmatic actions that can happen at a sub-federal level, which is also extremely important. And then we've spent time today talking about where the system has fallen short with equity. And so, once again, not in terms of staying in one's lane or not, but this is also a chance to keep doing the things that we can do across an ecosystem to build equity at the same time that we worry that it's slipping through many people's hands on lots of fronts. I'll stop.
Great, thanks, Jewel.
Can I jump in
Dean.
before Dean goes in? Because I want to just, I don't know if Dean's going to change the subject. That's why. Are you going to change the subject, Dean, on us? And I think about MLD as well in this answer, meaning that what Jewel just said is exactly, I think I'm asking about a crystal ball here, right? And right now, we did see the disruption on the federal level, but what I'm seeing from the state level, and RDDC does some state work as well, is Texas, New York, Minnesota, Florida, they've added additional panel screenings to or additional tests for some of these rare diseases in there. So I'm seeing at least an uptick, better movement. And maybe because I'm sitting in the patient advocacy side, I'm seeing more and more patient advocacy organizations being louder and being more upfront and talking about what's going on everywhere from the Medicaid perspective, which is also a state issue, everywhere from that to the newborn screening perspective. So my crystal ball is showing that it's not going to go away. If anything, what I'm hearing from even state representatives, because I know what's going on the federal level, is they are encouraging folks to work with the state representatives even more closely, especially for this next year and a half or so. So that I just want to provide that perspective. Sorry, Dean, go ahead.
Oh, no worries. Jewel, I love your analogy of not staying in your own lane. I think it's important. We've had a lot of conversations, particularly about equity today, and some of the islands that are not served and so on. But I think it's important for us to, as we close on a bigger note, we are all driving down that highway together. And I agree, we shouldn't stay in our own lane. It's okay to change lanes, come back, and so on, help each other out. But fundamentally, this is and Jewel, you started off by saying this is a huge ecosystem with a lot of different moving parts and pieces, and they're not all the same shape and size. And but it all fits together, and it is working. Newborn screening's not gone. We're all going to go back to our jobs in some way or another in a few minutes, doing newborn screening. So I think there's federal issues, there's state issues, there's lab issues, there's public health issues, which are at the state level. Separate. I separate them slightly from the lab because I think of them as the science and more the people facing side of that. There's appropriations, there's policy and legislation. I mean, there's so many places to engage, and all of you can cross a lane and come back. We are all in individual cars driving down that highway. It's 28, 30, 50 lanes wide. But please, we're on that journey, but we can't just show up at webinars. This is a time, and I think it's actually an opportunity. There's change going on, and it scares us, right? There's the big disruptions along the way here, but it's an opportunity to come back bigger, better, stronger, more efficient, more productive, solving some of these problems and so on. So let's seize that moment. I'm optimistic.
Great. And I think probably that's a great way to end, Dean. I agree that this is the most troubling time I've seen in the 30 years I've been involved with newborn screening, with genetics, with rare diseases, and it probably holds opportunity like any troubled time. Very difficult, and especially for underserved and marginalized communities suffer much, much more, I think. So I want to thank the National Academies for having put this committee together. I want to thank you, Jewel, for having led it, others for having served on the committee, Beth and many other committee members here as well. Great to see many old friends and the names on the screen. Some of us have more than gray hair and wrinkles. We have a history here that's quite astounding when we think about how many rounds we've made. And that progress is being made. So I'm very happy that in this case, we had 107 people lane highway, and we hope that we can continue to work together. There's a third webinar. Unfortunately, I'm blanking on the date. Maybe Emily knows. And we certainly will be pushing that out to all of you in our website and on our news lists and on our newsletter as well. And this recording and the recordings from all of them are on the Genetic Alliance YouTube channel. That also has a playlist for this specifically, and we'll be pushing that out to you as well in the form of our newsletter. The 14th, thanks, Heidi. So on the 14th will be the third and final of this series. And as has been said, let's do more than webinars. Let's really figure out how we can work together. Thank you very much.